Good evening, doctors. On behalf of Microlabs, we extend a hearty welcome to all of you for this second edition of Beating Heart, a monthly webinars. And thank you very much for gracefully accepting our invitation to be part of this evening session. It's an important year for us from Microlabs as we are entering into our 50th year of our inception. I'm sure you would appreciate and agree that very few companies travel this distance. And we have not only traveled this distance, but also done our best effort to improve ourselves in terms of our abilities and competencies to be one of the best pharmaceutical organizations in the country. So thank you very much for being part of our journey, part of our growth, and we are grateful to you people. So, without wasting much of the time, I would just want to introduce the chairperson for today's session, who is Dr. Rajesh Badani, who is a senior interventional cardiologist in Aditya Birla Hospital, Pune. And the speaker for today would be Dr. Umesh Khanna. And I request Dr. Rajesh Badani to introduce the speaker and the topic for today's session and then moderate the session for us. Thank you very much and welcome to Dr. Rajesh Badani and Dr. Umesh Khanna. Over to you, Dr. Badani.
Thank you, Mr. Samak, and good evening. Thank you, Microlabs, for giving us this opportunity. So, as we all know, we already have hypertension is one of the commonest problems. It's the commonest non-communicable disease which causes mortality. The mortality rather exceeds many of the cancers also, and is the number one disease. The prevalence is close to almost 27 to 33%. So, every 1 in 3 persons is hypertensive. And as we all know, one of the commonest causes of secondary hypertension is chronic kidney disease, which many a times is undetected. Many a times people are unaware, directly come to us with creatinine of 7, 8, 9, BP is 200 by 100, and we have nothing to offer these patients primarily other than a renal replacement therapy. One of the biggest nightmares as a cardiologist for us is somebody who already has a creatinine clearance which drops to below 30, and the patient is also hypertensive, and it becomes a great challenge to managing these patients from blood pressure point of view. So today's topic is going to be managing hypertension in patients with chronic kidney disease, and we have with us Dr. Umesh Khanna sir, who's a very senior nephrologist from Mumbai. He is the director of Kidney Associates in Mumbai, director of Lanceolate Kidney and GI Center at Borivali, and director of Lanceolate Nephro Plus Dialysis Center. He is an honorary consultant in the majority of suburbs in Nanavati, Vileparle, Wokhad, Mira Road, Karuna, Borivali, Namaha, Kandivali, Tunga, Suchak, and Asian Heart at Bandra, BKC. So I think without much delay, I would request Dr. Khanna to give his talk. I would request all the other members who probably have any questions, please put your questions in the chat box during the talk, and we'll try to address them as many as possible in the stipulated time. Welcome, Dr. Khanna, sir, and over to you, sir.
Thank you, Rajesh, for those kind words. And it's going to be a jugalbandi of a cardiologist and a nephrologist.
Correct.
Most often we are friends. Occasionally we are at loggerheads with each other.
That too temporarily, I believe.
So, and welcome all the friends who've joined us today for this session. Can we have the first slide, please? Thank you, Micro, for giving this opportunity. Yeah, I think the topic is hypertension, CKD, navigating the treatment landscape. And as Rajesh said, sometimes the navigation is a challenge, and quite often it's pretty straightforward. I must acknowledge my partners. We run a Kidney Associates group. It's a group practice. And today's talk, special thanks to my partner, Dr. Neil Saldana, for loaning me some of his slides. Now, again, hypertension is such a simple topic. So why are we discussing it? There are some unsettled issues in hypertension. The United States and the rest of the world don't agree what is normal blood pressure. We also don't agree on how to measure blood pressure. Simple thing. Office blood pressure, out of office blood pressure, home BP monitoring, ABPM, smartphone se check karo, central BP. And there are different trials are using different methods, and therefore there is slight discrepancy in what is hypertension. Of course, today's mantra, all of us know, is called standardized BP measurement. I don't know. I find it very hard. Someone should explain to me what is standardized BP measurement. It's such an impractical thing. In Mumbai ke consulting room mein, try and find a silent room. How do you do 3 readings, 1 minute apart? Everybody is in a guy to come inside and go out. The consultant is also in a hurry. He has so many patients waiting outside. Relaxed. When would the patient be relaxed? I don't know. He has to be quietly seated for 5 minutes. Bladder should be empty. Many consulting rooms don't have a toilet only. Legs uncrossed. The only thing is no exercise. The patient should not be exercising. That's pretty simple. Which instrument to use? It should be validated. I don't know how to validate the instrument so easily. So how do you expect a primary care physician to get instruments which are validated? So there are issues which are still unsettled and difficult. And then there are controversies and discrepancies, and most of our guidelines are based on these two modern trials, Sprint and Accord. And yet when I talk as a nephrologist, KDIGO decides 120 targets based on just one study. So if we all try to go for the target, try reaching the target in oldies, in frail, in white coat hypertension, etc. And there is a lot of disagreement between nephrologists and cardiologists, which means KDIGO and ESH, the European Society of Hypertension, about the targets and so on. So there are unsettled issues in hypertension, and yet there are many things which are absolutely settled in hypertension. So we will try to see what is easy and proper. Let's take a case. Mr. Bipin Bhai. He's a 44-year-old male, no prior comorbidities. He complains of headache, dizziness since a week. The initial routine labs show a creatinine of 1.9, GFR 54 after a standardized measurement protocol. His mean office systolic BP is around 165, diastolic 95. How do we further manage this case? So, I'm still in that habit of Zoom, and next slide goes through my computer. Anyway, so measurement of blood pressure, we all know, is standardized office measurement, attended versus unattended. These are the two methods in which you measure the blood pressure. Oscillometric device versus manual device, home BP versus ABPM. And therefore, the blood pressure measurement may, why oscillometric BP device is preferred to manual, because manual comes slightly higher and there are issues of measurement and human errors which are there. But when you talk of standardized BP measurement, more than the instrument, it is the adequate preparation of the patient for BP measurement and not the type of equipment which really should be standardized. The automated BP, either attended or unattended. So the ideal method in many of the trials is the patient is unattended, and that seems to be a preferred method of measurement. The oscillometric devices can be used to measure blood pressure on patients with atrial fibrillation and gives a better result. The advantage of oscillometric devices may increase likelihood of adherence to proper BP measurement protocols, removes potential inaccuracies with manual measurement, and may reduce the white coat effect. The staff gets relatively free, used in prior RCTs. Now, of course, different trials use different methods. Guidelines regarding proper techniques, everybody knows. But as I said in the beginning, yes, in theory, it is perfect, it is good. In practice, there are issues. Sometimes there are difficulties, and it's almost like an ideal world in which you must measure blood pressure. But that's the best way of measuring. Yeah. What about definition of hypertension? Nowadays, it is taken that your definition vary whether you're talking of office blood pressure, ambulatory blood pressure, home BP, and different guidelines give you different figures. So ACC, American Heart Association guidelines, ESC, European guidelines, they differ predominantly in the sense that European is slightly higher, almost 5 to 10 millimeter higher. If you see, the clinic blood pressure in ACC is 130 by 80 is considered as hypertension, while in ESC, ESH, it will be 140/90. Same different values in home BP, daytime ABPM, because a lot of people abroad are using ABPM as one of the methods of measurement. Although in our country, ABPM is available, but not as frequently used and used only occasionally. So these measures or these methods, one should know about the values before labeling somebody as hypertension. So again, they differ So these guidelines are ACC, ESC, Australian, Canadian, and KDIGO. If you look at it, KDIGO is the one which tries, that's the nephrology guideline 2021. It's much different from the 2012. And we try to bring it down as low as possible to 120. And we'll discuss KDIGO guideline later on. And here there are subgroups: those with no diabetes and proteinuria, those with proteinuria, CKD diabetes, both combined, renal transplant, and elderly. So all have different figures, and I would not want to bore you with what is the best target to achieve or the definition of hypertension there. But if you compare American and European society in the definition of hypertension or the target achieving in the hypertension, the difference is generally of about 10 millimeter. European people prefer to have it slightly more, and Americans are more stringent about the targets and the definition. What about Indian guidelines? So 2019, we are again following more towards the European guidelines and target. So high blood pressure is equal to or more than 140/90 for office reading. Home BP and ABPM mean daytime is 135/85. In 24-hour ABPM is 130/80. Threshold for starting drugs should be 140/90. This, of course, is much higher than what the ACC guidelines talk of. And target in coronary artery disease, CHF, proteinuria, try to achieve less than 130, especially in patients who are younger, less than 60 years of age. And in nephrology patients, try and reach more towards 120. In elderly, again, 130 to 140 systolic, 80 to 90 diastolic. These are the Indian guidelines 2019. Let's take renal hypertension. It's always a chicken or egg hypertension story. Is renal dysfunction likely to lead to hypertension, or is it hypertension leading to hypertensive nephrosclerosis? More people believe that it's the renal dysfunction that causes hypertension, and hypertensive nephrosclerosis is slowly being debated. Now, whenever you have a patient who is suspected to have renal hypertension, there are important points in the history one has to note and do. Duration of hypertension, again, is important. Whether any agents history that may cause hypertension. This is, of course, true for any hypertensive, not necessarily renal hypertension. And then you look out for symptoms of secondary causes of hypertension. Look out for target organ damage. This is pretty simple. Most people know about it. Specific to renal dysfunction is to rule out conditions which may be associated with renal insufficiency. We all know that symptoms of puffiness, pedal edema, change in the color and consistency of urine in the sun in the form of proteinuria will present as frothy urine, and obviously reddish or darkish urine would be meaning hematuria. But importantly, many of the renal conditions like glomerulonephritis would present with an upper respiratory infection or skin infection. A lot of CKDs just present asymptomatically or sometimes only with mild fatigue. But the systemic diseases like vasculitis, lupus, etc. will present with symptoms of rash, ulcers, etc. And some vasculitis will present more with pulmonary catastrophe in the form of hemoptysis, etc. But you must also examine and look out for renal bruise, enlarged kidneys. Again, ADPKD is the fifth commonest cause of CKD, the polycystic kidney disease. So one should look out for that. And we know the clinical features of lupus in the form of rash, etc. Now, when you evaluate a patient with hypertension, renal dysfunction, we should now not rest with creatinine measurement, but we must measure EGFR. EGFR, most recent laboratories or most prominent laboratories will give simultaneously along with creatinine EGFR. Obviously, in all hypertension, wherever you're suspecting a renal cause, you will ask for a renal profile, but urine analysis forms the bedrock of any investigation of renal hypertension. And proteinuria, RBCs, dysmorphic RBCs and all would give a clue of glomerular diseases. Renal ultrasound, we all do it for all hypertensives, especially if you suspect a hypertension due to renal disease. Doppler in patients who suspect a renal artery stenosis. But once you have albumin 1+, 2+, 3+, or whatever proteinuria, don't get satisfied with just a urine routine analysis, but always ask for spot urine protein creatinine ratio or a UACR albumin creatinine ratio, because that would help in quantification of proteinuria and tell you the severity of proteinuria, severity of CKD, also about whether it's a nephrotic syndrome or a glomerular disease. If you have an elevated creatinine and hypertension, diagnosis of a renal disease is obvious. Look for a reversible cause. So first test is renal ultrasound. Once you do a renal ultrasound, if you have normal size kidney, preserved ecotexture, good corticomedullary differentiation, it is not CKD. So you look out for um, tier 2 kind of investigations. We just rattled off the investigation in renal disease. These would be those cases where you have ultrasound almost normal and you have other features of renal disease. So you must look out for systemic disease, glomerular disease, say 3, ANA. For vasculitis, look out for MPO and PR3 ANCA tests. And never forget, in an elderly person, serum protein electrophoresis. Quite often you'll end up doing a renal biopsy in many of these patients. But more often, if you have long-standing hypertension, CKD, you get smaller size kidneys, mostly smooth, hardly any scars, increased ecotexture, loss of corticomedullary differentiation. That's your typical hypertension and CKD patient. And these patients, what you have to do, you have to plan, you have to label him as CKD, of course, with the help of other parameters like anemia, hyper phosphatemia, hypocalcemia, a patient who is absolutely comfortable with his creatinine of 7, 8, 9, as Dr. Rajesh said. These are the people who are more of CKD. So in these patients, obviously, there are many things to do. Anemia management, CKD, MBD, that means bone management, vaccination with hepatitis B, etc., etc., and the standard treatment for CKD, which today's topic obviously is not geared up for treatment of CKD. What about so-called essential hypertension and missing out of primary hyperaldosteronism? That is something which has come out very well in 2022 and 23, that there is a higher incidence of primary hyperaldosteronism and people are missing primary hyperaldosteronism or secondary hypertension due to it in lot many cases. And in some trials, it is quoted as almost 10 to 15% of primary of so-called essential hypertension could be primary aldosteronism. So whenever you have hypertension with hypokalemia, drug-resistant hypertension, or an ultrasound or a CT picture of adrenal incidentalloma, they are the cases where you need to definitely do plasma aldosterone concentration to plasma renin activity ratio. So the new emphasis in many cases of hypertension is you must rule out a secondary cause of hypertension. Let's come back to our case. What about the story of Bipin Bhai? So his hemoglobin was 11.7, platelet count almost normal, creatinine 1.9, potassium okay, albumin 3.6, but his urine showed proteinuria, RBCs and WBC, and his urine protein creatinine ratio was 2.2, which is significant amount of proteinuria, more in favor of a glomerular disease, and his ultrasound showed a corticomedullary differentiation issues, and that was preserved, but the kidney size was normal, and which is why he was advised to undergo a kidney biopsy. His blood pressure readings used to be still on the higher side, only 160/90. There was frothing in the urine, there was edema feet, headache, and sometimes blurring of vision. So this patient obviously had kidney disease with blood pressures which didn't seem to be controlled. So the biopsy, of course, was done, and the biopsy diagnosis was IgA nephropathy. You'll be surprised to know that other than diabetic nephropathy, one of the commonest nephropathy or nephrotic syndrome or glomerular disease is IgA nephropathy. It can present with either nephritic syndrome or nephrotic syndrome, or just asymptomatic urinary abnormalities, and of course hypertension. So in patients who are hypertensive and have proteinuria or an active urinary sediment, you must look out for IgA nephritis. How do you manage? So in his case, again, it's the same as in any other hypertension: aggressive control of blood pressure through lifestyle, pharmacological agents, etc. And if feasible, every kidney patient, our first attempt is to treat the underlying cause of renal dysfunction. Like in this patient, he had IgA nephropathy, so one would want to treat it as much as possible. Let's see. Okay. So the first step in any hypertension, I don't have to inform this audience who is quite knowledgeable. Just to revise, it's physical activity, dash diet, salt intake reduction, caution over the counter medication. This is something which in history we miss, and one has to take pains. You have to be like Sherlock Holmes to find out what medicines he's taking. Ask him to get his pill box and see what are the medicines he's taking. A lot of them are on herbal medicines for weight loss, etc. And these are some of the medicines which can lead to hypertension, apart from the standard NSAIDs and so on. Stop smoking. No, nobody needs to get a medal for asking people to stop smoking. But obstructive sleep apnea is something which goes unnoticed, or at least a physician in his busy practice would forget to talk or diagnose obstructive sleep apnea or send him to the appropriate person. And of course, weight loss or exercise and all is common. We all know about DASH diet, 6 to 8 servings of whole grain, nuts, seeds, legumes, 4 to 5 servings per day of vegetables, fruits. But the important part that has come out in many of the studies in 2022 is the importance of high potassium as a treatment for hypertension. I think in the Chinese study, uh, the Chinese study, they had shown clearly that substituting normal salt with low salt, that is higher in potassium, the blood pressure did come down. So that's the importance of it. What BP target will you aim for Bipin Bhai? So this is basically not the story of only Bipin Bhai, but anybody who you need to control blood pressure. So blood pressure target is another issue which we just talked in passing. But in CKD patient, KDIGO brought out this guideline in 2021. Adults with high blood pressure and CKD should be treated with a target systolic blood pressure of less than 120 millimeter. But remember, using standardized office blood pressure measurement. In practice, there is no way to extrapolate it, but roughly it would amount to say 130 in the normal way in which we measure blood pressure. But don't quote me as the extrapolation, but roughly when you talk of standardized blood pressure measurement of less than 120, then in the way we measure blood pressure, it would be definitely much higher. Now, this recommendation, even KDIGO mentioned it as level 2. It was weak. And according to the grade, it was moderate. So because there is less certainty that the benefits outweigh the risk, but keeping in mind the people who gathered together, they had a lot of clue from Sprint, and hence based on that one pivotal trial, they brought it down. So what was the rationale for the target of less than 120? For most patients CKD, remember that the heart is king. Why is the chairman a cardiologist and not a nephrologist? Heart is king. Cardiologists are superior. And therefore, a cardiovascular event is more likely the outcome than ESKD. So most patients don't end up to the stage of dialysis. They die much before that. In fact, there is a saying in nephrology that only the lucky ones reach dialysis. Most of the others succumb due to either coronary artery disease or cardiovascular events and so on. And hence, Sprint also confirmed cardiovascular and survival benefits in non-diabetic CKD. Remember, non-diabetic CKD. Accord showed marked reduction in stroke in diabetes, but only included 401 diabetic patients with EGFR less than 60 ml. Nonetheless, the benefits of less than 120 in the standard glycemia arm in Accord also, the benefits were seen like in Sprint. So basically, based on all these, based on the cardiovascular benefits, the target of less than 120 was given by KDIGO. It's also that the meta-analysis demonstrated reduction of CV risk proportional to BP lowering, and hence I think we all kind of accepted the guideline of KDIGO in CKD to try and bring it down as low as possible, preferably below 120. So many other trials also showed that intensive versus less intensive lowering, there is roughly 14% benefit of intensive lowering. This is the Sprint trial in which they have definitely shown that a BP target less than 122 versus less than 140, there is independent of age, etc. There is a definite benefit of cardiovascular benefit. Now, what are the implications? Guideline to de diya. What to do next? If you are in America, Based on the 2021 KDIGO guidelines, 69.5%, that means 70% of US adults with CKD would be eligible for BP lowering. And among those with albuminuria, almost 80%, 78.2%. But how many are receiving ACRBs? 39%. The same is the seen in India. SGPGI Lucknow did a trial. Roughly between 30 to 40% of the people only who need ACRBs are taking ACRBs. The same rule as how SGLT2 inhibitors are being given by less than 30% of the patients who require or deserve the use of it, whether it's inertia or whatever. So, the KDIGO 2021, I know we are not having nephrologists in the field, but since we are talking of CKD and hypertension, the Bible in most guidelines in nephrology has been generally KDIGO. And therefore, this time's 2021 hypertension targets is a little more controversial than many of the other guidelines in nephrology that has come up from KDIGO. So, this definitely calls for a debate. What are the controversial points? Most people don't use standardized BP measurements as recommended. Most doctors measure attended blood pressure, not unattended BP measurement. Sprint and Accord both measured unattended blood pressure. KDIFCO defines high blood pressure means systolic above 120. It doesn't talk of diastolic. And KDIGO drew heavily on that one major trial, Sprint, which had large number of non-diabetics, aged more than 50 years, and EGFR between 20 to 60. Proteinuria less than 1 gram and systolic BP 130 by 80. So basically, it did not have a fair representation of all that you are going to see in your own practice, but it broadened its recommendations to everybody, except children, dialysis, and transplant patients. It said for almost everybody that you must try and bring it down to 120. Only thing, it put a caveat that this is of less certain benefit. That's all, whatever it means. My English is a little poor, but it just said that it is of less certain benefit. So the other issue is that there is always difficulty to reach target of 120. And if somebody hasn't gone into the details of it and tries to bring down 120, not with the standardized BP measurement, but with a routine, then reaching the target of 120 becomes difficult. And sometimes if you go much below 120, especially in the evening or night when patient is sleeping, there could be a little history of fall, etc., in frail patients. So it should be taken in accordance with individual patient. There could be a little higher incidence of strokes with BP below 120 target compared to 130, 140. So it's instead of a single target, it will always be good to have not a one size fits all approach or a target oriented approach, but risk reduction approach of every patient. That would be a good way of handling it. What's the approach for antihypertensive drug therapy? And we all know that a single pill approach is presently considered as one of the best way of treating hypertension. Generally a dual combination to begin with. ACRB plus CCB is generally the favored. This is the flavor of a couple of years last, either with calcium blocker or with diuretic. ACRB in any nephrology discussion, illness, disease, except for bilateral renal artery stenosis or people who are greatly volume depleted, etc., ACRB would still become the numero uno drug. That's the number one drug. So you should try and consider single pill, but dual therapy. You can consider monotherapy in very high risk mild hypertensive or those who are elderly with more than 80 years or frail. Those patients, you can start with a single pill. What about step 2? If dual is not sufficient, then you could add a triple combination, ACRB plus calcium blocker plus diuretic. That's, I think, fairly simple. Most of us are aware of it. And step 3 is where you introduce 2 pills, in which case you got to first find out or diagnose whether it's a genuine resistant hypertension, in which case, again, the flavor of now these couple of years is to add spironolactone. So MRA or mineraloreceptor antagonist is now very well accepted as a method of treating difficult to treat hypertension. And of course, with the new drug finerenone, we are shifting it to its use in proteinuria and diabetes. You know that finerenone is not a great drug for hypertension control, but spironolactone would be a great drug to control genuine resistant hypertension. What about beta blockers? Yes, it would be used as definitely a step three, and consider it at any treatment step when there is a specific reason for the use of it, like heart failure, angina, post-MI, atrial fibrillation, younger women who are planning pregnancy where ACRBs, etc., cannot be used, and so on. So we are probably familiar with this grid of how to manage hypertension. What is your approach to hypertensive therapy? I think somebody put it up on the chat box when to start ACRB, and I think no discussion with a nephrologist or a cardiologist or a cardio-nephrology team is complete without discussing ACRB. How do you start ACRB? When to continue? When to stop? And so on. So ACRB is, at least we have learned a lot on how to use ACRB. It was considered earlier as a double-edged sword. No longer now, because we are very well aware of its utility and how to use it and discontinue, etc. So continue therapy unless serum creatinine rises by more than 30% within 4 weeks. A slight rise in serum creatinine is quite common. In fact, it is considered as a good omen. That means it will be more effective. But beyond 30% within 4 weeks, then it's a red flag. There are areas which would lead to a little high creatinine if you use ACRBs, and the best way to manage the side effects of ACRBs would be to look at whether the patient is on diuretics, volume depleted, try and make him euvolumic, volume replete. You can stop for some time ACRBs, or stop diuretic first, bring up the volume status of the patient, then add ACRBs, in which case the side effects of high creatinine are much less in these patients. Of course, you would rule out renal artery stenosis if there is a doubt for it. In young women, advise contraception who are on treatment, or discontinue if you expect them to become pregnant soon. The other main issue is hyperkalemia, and this is again in 2022 and 23, hyperkalemia, CKD, proteinuria, LV dysfunction patients, when you use a lot of drugs which are very good drugs but causing hyperkalemia, like ASARBs, MRAs, Vimadas. So when all these drugs are used, which are excellent drugs in given situation, but there is a fear of hyperkalemia, one has to be very careful about the diet prescribed. You should check whether they are not on potassium kind of salt. That means low salt, which is uh, not pure sodium chloride, but is mixed with um, potassium salt. Then in those cases, you will have to change their diet and uh, try and use potassium lowering measures. Abroad now we have two drugs, patiromer and zirconium, which are being available for us to use maximum doses of ASARBs along with those drugs, so that hyperkalemia doesn't become an issue at all. For now, for us, it is prohibitively expensive because it needs to be imported, and only the super rich can afford the combination of these potassium lowering drugs along with drugs which would say like finerenone and MRAs and ACRBs. You must reduce or discontinue whenever you have symptomatic hypertension or uncontrolled hyperkalemia. And this one line is your take home today. Always educate the patient about sick day rule. When you're using ASARBs, when you're using MRAs, when you're using SGLT2, when you're using finerenone, if the patient becomes sick due to gastroenteritis, or there is a surgery, or there is malaria, dengue, etc., during those days, the ACRB has to be stopped. And always use only one out of ACE or ARB. This, of course, is known to most of us. What about resistant hypertension? You first rule out whether the patient is taking the drugs properly, adherence to the drug, reinforce the lifestyle so that his blood pressure comes down with lifestyle changes, optimize the current dosage of blood pressure medicines or combinations. In fact, the quartet dosing is now considered a good way of, that means 4 pills, smaller doses. Add-on options would be MRS, beta blockers, sympatholytics, alpha blockers, vasodilators. So these would be drugs to be added if you have resistant hypertension. Let's come back to our case. What did we do in our BIPIN pipe? Two parts: control of hypertension and management of the underlying disease. Control of hypertension almost the same. He was initiated on telmisartan and amlodipine, advised home BP monitoring. His blood pressure doses were titrated. Telmisartan was increased as there was no hyperkalemia or increase in creatinine. And based on the blood pressure required and controlled, the doses were adjusted. But more importantly, because of his biopsy, his underlying cause was treated with steroids, and with that his blood pressure came down, creatinine came down, proteinuria came down, because steroids are good for IgA nephropathy in moderately mild to moderately severe patients. So we are coming closer to the end. Managing hypertension in 2023. Is there anything new? Since this slide was made more for the nephrology audience and I didn't want a fight with the cardiologist, we could always have a debate later on with Rajesh on some other forum. That as nephrologists, it's our job to take ownership of managing hypertension. Hypertension is a renal issue. Cardiologists are too busy doing angiographies. Lower the blood pressure. A lower blood pressure may be better in most patients and subgroups. Carefully lower blood pressure targets. Rajesh, I was joking. Carefully lower blood pressure targets to as low as possible in most patients possible. This is how I interpret KDIGO 2021. That means even if all patients may not be subjected to the lower target, do it in as many as it's possible. RAS inhibitors are still the champion drugs in hypertension CKD, especially those with proteinuria. In non-proteinurics, yes, there could be a debate of it. Arrival of newer agents in managing hyperkalemia, as I said, patiromer and zirconium will allow more liberal use of RAS inhibitors. Remember, cilnidipine, benedipine, ifenadipine, and other new add-on drugs may help in reducing proteinuria to a small extent, but you need many more studies. Of course, the Japanese trials do show that the calcium channel blockers, L and T types, are much useful. You must have heard of the CLICK trial, wherein chlorthalidone did help in bringing down mild proteinuria also and blood pressure control. So use of thiazides is important. As I was mentioning, quartet pill, that means very tiny doses of 4 drugs. This has one of the trial has shown it to be very effective, and maybe we'll hear a lot more about it in the next year. Rise of mineral receptor antagonists for difficult to treat hypertension, and when you use patiromer, it will be very easy to handle MRS. The last word is still not spoken on denervation trials, but for now, I think they are still evolving. We need to recognize and treat more primary aldosteronism in the so-called essential hypertension before you label somebody as essential hypertension. So my last slide, hypertension renal dysfunction does not always equate to hypertensive nephrosclerosis. The chicken and egg, the cause and effect. Always look out for an underlying cause in a case of hypertension renal dysfunction with normal sizes and kidney and good ecotexture of kidney. So you may have to refer to a nephrologist for biopsy, etc. ACE/ARBs are the medication of choice. Before evaluating further for resistant hypertension, look out for patient adherence and offer as intensive BP lowering therapy as possible in most patients, except in very old, fragile, and limited life expectancy patient or those with symptomatic hypertension. Thank you so much for patient hearing.
Thank you, sir. It was an excellent deliberation, and I think you covered almost the important aspects for renal hypertension, the etiology, the drugs, as well as probably the most important message for everybody is that please start doing proteinuria evaluation, which is there in most of the patients, so that those differentiate the patients who are genuinely at a very high risk, which can probably be maximally treated with an ACE inhibitor or an ARB. Thank you. So I think now, sir, I will just start the discussion. There are a few questions, but before
So
that,
the best part is since I have spoken a lot, now it will be Rajesh Badani's turn to take all the questions. Yeah, please,
okay,
please.
no issues. Sir, the only thing I wanted to ask you is from a cardiology perspective that when you are thinking of evaluating proteinuria in patients, which, because there are multiple things that people can do. You can do a microalbuminuria, you can do a UACR, and you
Right.
probably even do a what do you say, the
24 hours protein.
24-hour urine protein. So amongst
Yeah.
them, from a clinician perspective, how would you differentiate which one
So
to
I
do
think
what?
the moment your urine shows proteinuria, that means the spot, the urine analysis report from your standard lab comes as albumin 1 plus 2 plus or whatever. The best investigation to immediately order is a spot urine albumin creatine ratio, because that's now the standard teaching to everybody, especially in diabetics and hypertensives. If you're suspecting a nephrotic syndrome or a glomerular disease, then from the nephrologist point of view, we sometimes order spot urine protein creatine ratio rather than an albumin creatine ratio. But for the physicians, cardiologists, I think the best way is to just go ahead and get a UACR done.
Yes, yeah.
Microalbuminuria term is nowadays almost given up, and everybody talks of only UACR. So it's mild, moderate, severe rather than micro and so on. Yeah.
Perfect. So I believe that is one thing. Secondly, I believe you spoke a lot about, so one, a couple of points which I thought I want to make about the diagnosis of hypertension in terms of our general population, or even the patients who have CKD, is then ambulatory blood pressure, if they are able to afford, you should
Correct.
probably do, because most of your CKD patients are going to be nocturnal non-dippers or reverse
Non-dip.
dippers.
Absolutely.
Yes,
So
and
I think
this
a
is
good point that you have made, and because of lack of time, we didn't touch on ABPM. But I think as cardiologists, you all use a lot of ABPM, and we also have started using for the same reason: non-dippers and reverse dippers, and early morning hypertensions, and so on. So, which is a very important diagnostic tool. Yeah.
because we had one trial, I believe one of our nephrology student had done it, and almost 65% of the CKD patients were probably non-dippers or reverse dippers. And I think, as we said, it's a nightmare for a nephrologist at least to control the blood pressure. Once the patient goes beyond CKD stage 4 or 5, becomes very
Absolutely.
challenging to get your
Most
BP
of
at
them are 3.5 drugs.
correct, sir.
Most of them are on 3.5 drugs to control.
Okay, so one question: if at all you have to choose between an ACE and an ARB, now you have believe that's a moderate CKD which is there, and this patient's creatinine is, let's say, 1.7, 1.8, and you believe proteinuria is not really that significant, and this fellow is coming to you with a BP of around 170, 100, what would be your choice amongst the RAS inhibitors that probably you would want to use? Is it an ACE inhibitor, an ARB, and maybe what do you use in your practice, sir?
So there was a song, हर युग के बदलते रस्मों को कैसे आदर्श बनाओगे. These trials keep coming every couple of years. Some days ACE is superior, some days ARB is superior. And since we all know about, the flavor is added depending on which is the new modern drug that has come in. To me, I think it's a class effect of ACE ARBs together. I would interchange between ACE ARBs. Right now, we are a little more comfortable with ARBs, and that too with a little longer acting like telmisartan and some of its other similar longer acting drugs rather than the short acting like losartan, etc. So I would probably are a little more comfortable. So it will be individual
Okay.
using ARBs versus ACE. So I think the
So
answer would
absolutely,
vary with.
and yeah, so I believe what you're telling is right, but I think one pointer, if I can make from a blood pressure perspective, is that to achieve an 80 milligram dosage with a telmisartan is far more comfortable than achieving a 10 milligram dose with a ramipril in our practice. I think you have
Absolutely.
had far more
Yeah.
years of time when Cardace and ramipril was
Yes.
there.
Yeah.
But I believe maybe in whatever practice I have, I believe it's very difficult for me to reach a target of 10 milligrams versus 80 of
Mm.
telmisartan, which is there.
Correct.
What is your
So
take,
I
sir?
must tell you, Dr. Mani, you must have heard his name. He's the doyen of nephrologists. So he's a very
Yes.
strong believer of use of ACE-ARBs, and you'll be surprised. It's not. This got nothing to do with hypertension. It's more for slowing down the progression of kidney disease. He's a
Yes.
strong believer of using ACE-ARBs to that extent, and he uses enalapril up to 160 milligram and even beyond that enalapril. So this is his own. Nobody has duplicated it, but I'm just telling you that people have so much faith in either ACE or ARBs, and they go beyond it. But for practical purposes, I think telmisartan 80 milligram is what you'll be very comfortable using it. Although in some patients, I go beyond that also.
Okay, so now I think, sir, another question of calcium channel blockers you already have focused on. One pointer that we probably didn't cover is the nifedipine extended release preparation or the XL preparations, which probably they say they are long acting, and
Yeah.
maybe they probably preserve this drug for a true resistant hypertension. So, what is your take, sir, in your practice between I know
Um,
amlodipine, cilnidipine, and the newer and the nifedipine extended, the newer preparation? What is your take, sir, on that?
So if I have to shift from nifedipine and amlodipine, I generally use it more for proteinuria additional benefit to the ACRBs, and not because I'm very fond of using the other calcium blockers. I still use a lot of amlodipine and nifedipine, although there are disadvantages in CKD also, especially tachycardia, and doesn't preserve kidney function to that extent, doesn't help much in the proteinuria. The extended release or nifedipine extended release ones I've used in a few patients, and I find it good in terms of tolerance. But I think if you have really a bad hypertension, I would still go by my comfort level of using it, uh, standard nifedipine retard rather than XL. But having said that, all the newer calcium channel blockers also, although they are good in maybe reduced edema formation, I just said reduce. They also cause a lot of edema, but
Yes,
much
yes.
less nifedipine, amlodipine, etc. But again, they are not as strong as nifedipine and amlodipine in terms of blood pressure control. So if that is your main target, which it should be, then maybe one of the ways I do it is you start with amlodipine, nifedipine, and you find blood pressures very well under control. I switch to the uh, newer calcium channel blocker to get the other benefits in addition to it. But this is again our personal way in which we manage and not guidelines.
So I think it's a for the take-home message of the physician. It's a trade-off between proteinuria and BP control. Amlodipine very strong BP control, but not a great anti-proteinuric. Whereas cilnidipine and the other ones strong proteinuria, maybe better than amlodipine, less edema, but not zero edema. But
Yeah.
again, your BP control may be a challenge, which probably I think we are
Yes.
facing.
So I would add that BP control is the single most important one, and second would come calcium block. Second will come proteinuria.
Protein,
So therefore,
absolutely.
best is to switch from one to the other depending on what is most important in a given patient at that
Yeah, that's
particular
a
moment.
Yeah, that's a good idea to switch off.
Yeah.
Second, sir, I think question was, I think probably it is which drug is better in young hypertensives, bisoprolol or metoprolol? I think I'll take that
So
up
that's a
for the
cardiology question.
correct. So I think from a point of view, if you remember Sir's slide on management of hypertension of resistant, we have a data telling that after spironolactone, there are two drugs, doxazocin and bisoprolol, which probably have been used or they have been indicated in patients with resistance. So I think a young patient who has sinus tachycardia at baseline, I think the best part is amongst the two, cardio selectivity wise, bisoprolol is little more as compared to metoprolol, and BP control wise it is nearly at par. It's like 12.5 and 2.5, 25 is 5, sorry 50 is 5 and 100 is 10. The advantage with bisoprolol only thing is cardioselectivity as well as the other side effect profile, which is there is a little bit favorable, though to say we cannot really differentiate because both the drugs are approved in heart failure at the same time in hypertension also. But little bit of a preference now, as sir said, badalte samay, now we have a lot of data on bisoprolol coming in, so we have been using little more of bisoprolol as compared to
Yes,
metoprolol.
definitely the flavor of again the season is still Bisoprolol. I call it
Correct.
flavor because it keeps changing. That's it.
Changing, very very true. Then I think they just somebody just wanted to know, sir, what is stage 5 CKD for the purpose of understanding, sir. If you can just give them the
Stage 5
grading of.
CKD is based on GFR. If all stages are based on GFR and proteinuria. So if your GFR falls below 15, then we call it stage 5 CKD. If you are on dialysis, then we call it stage 5D CKD.
Correct. Sir, another question, which antihypertensive, this is very important from a physician perspective, are contraindicated in CKD? Maybe relative or an absolute, whichever way. Which ones are the
Okay.
ones which you would?
So there are basically, as we discussed about ACRBs, if you have a patient who is having hyperkalemia to begin with, we treat that before we start him on ACRB. So that way, as you said, relative contraindication at that moment.
Correct, sir.
Then I think the basic reason why, I mean, if you ask me, I use all antihypertensives in CKD. I don't call any drug as completely contraindicated. But we do face difficulties with beta blockers, which are not cardioselective. That's one area which we do find a lot of side effects of bradycardia, etc. Remember that when I talk of hyperkalemia and ACRBs, remember even beta blockers lead to hyperkalemia in addition to what the ACRB. So if somebody has recurrent hyperkalemia, then I will be not comfortable using a combination of ACRBs as well as beta blockers. We do use drugs which others don't use, like arcamine or clonidine. We use a lot of moxonidazepine. So that way, edema producing drugs, you could call it as relative contraindication in some patients. For example, minoxidil. We used to use a lot of it before MRAs came into the picture for resistant
Resistant
hypertension.
hypertension.
And minoxidil caused a huge amount of edema in a lot of patients. So genuinely, except in a combination of beta blockers and ACRBs, most other drugs I think can be used in CKD. Hardly any contraindication.
Okay, sir. So now one interesting physician-related question. Imagine person is a hypertensive. You are started him on telmisartan and chlorthalidone. Over a period of years together, his creatinine starts rising. And probably, let's say he was at 1.1 creatinine, and then probably now he's around 1.8, 1.9 creat. Then obviously we'll calculate eGFR. At what stage, sir, would you really believe that I need to hold on or be little wary about using continuing my thiazide like diuretics in these group of patients?
So almost all talks when I give this question of when to hold on ACRBs and sometimes when to hold on diuretics comes up as a question. So firstly, let's take ACRBs. There is no contraindication in any stage of CKD except for hyperkalemia. So the reason why you will not give ACRB is not the creatinine part, but the hyperkalemia. You need to be just sure that if the creatinine keeps on rising, find out whether there is volume depletion, find out he is having renal stenosis, etc. But otherwise, you can use it. Thiazides, we used to use it till GFR of 30, and below GFR 30, we had stopped. But now there are some trials which are showing that you can use thiazides even below GFR of 30. So if these two drugs you are asking the question, then I think you can. But I find a lot of patients who are having GFR below 60 will have a lot of side effects of diuretics, that means thiazides along with ACRBs in the form of hyperuricemia. A lot of people have hyperuricemia in addition to low GFR. I mean, in CKD patients, somehow the uric acid levels go up much more than the non-CKD patients in thiazides, and also hyponatremia if the patient is not restricted his fluid intake along with. So if he has edema and you use diuretics without restricting his fluids, then hyponatremia becomes an issue.
I was about to ask you the same thing. And in Indian subsets who have an insensible loss of sodium, maybe
Yeah.
in a humid atmosphere like Mumbai or something, I think your patients and clinicians should be very wary, and please get their electrolytes also so that you
Absolutely.
get to know
Which
about
is why I'm
sodium.
not a great fan of diuretic in patients who are not educated or who are not going to follow up with us. Your patient should be good follow up.
Yes. And how about, sir, the role of alpha blockers? At what stage are you comfortable adding it as a third, fourth agent? Or because that drug that way is technically a pretty good and a neutral in terms of metabolic parameters. And
So
there
in
are many drugs like
nephrologists
beta
use
blocker. Yes.
nephrologists use a lot of alpha blockers anyway. So that's because you are fed up with using three drugs and still nothing is coming under control. So it goes stepwise.
Very true.
ACRBs, calcium blockers, sometimes diuretics, beta blockers, cardioselective ones, and then you have centrally acting either moxonidine or clonidine, and you have prazosin or alpha blockers which are being used. We don't use doxosine, but we
Yes,
use
prazosin is the one which is there.
yeah.
So I think we have tried to cover, and we are in time. I believe 9:04. So I think
I
all the
think
questions
we
have
are
been
due
set.
for dinner now,
Yes,
and
yes, sir.
I'm not sure whether micro is going to give or we have to have it at home. So
No,
they
no.
haven't
Presently,
clarified.
though, we'll have to have it at home only. Because even if you
Well,
get down in Mumbai, sir, to reach a
Yeah.
place also, you will take another hour, I
Every-
believe.
Yes,
Fridays.
yes.
everything is
I think
virtual
we
now,
had a
sir.
nice discussion, and
Yes, sir.
Rajesh
It
has
was
conducted the session very well. So must thank Rajesh, and of course the audience also for being so interactive with asking
so to
many
end,
questions.
sir, I think it was truly a pretty good jugalbandi. So I think nephrologist and cardiologist really go hand in hand.
Yes.
The only
Thank you,
part where
Sirish.
uh,
I was telling thank you,
Yes.
Sirish. So
It's
it's
a
a good
pleasure.
thing.
Pleasure was ours, sir. I think like
thank
one
you.
of the senior nephrologists says, heart is the kidney of hypertension. So,
Yes. Nee, nee.
so
The
I think
heart
thank
is
you very
always
much. We had
king.
wonderful,
Whether we
yeah.
talk of kidney or heart is king.
Or
Numera, you know
kidney is
it.
the heart of hypertension.
Yes, sir.
We
All
can
right.
tweak it the other
Thank
way
you.
around. So,
All
thank you,
right.
sir. It was a
Thanks,
pleasure
Rajesh.
having you and wonderful deliberations. And thank you, Dr. Rajesh. I think we had close to 600 people watching us on two different platforms. One was the direct and other one was the through Facebook
मैं
and
मैं तो डर
YouTube.
जाता था अगर पहले बोला होता था यार.
Sir, sir, and other thing is that we have, since being a series of webinars, and we have a lot of people who have been common audience for us. I think this is a good platform for us to build a common set of audience.
Sure.
Thank you very much, sir. Thanks to both of you, and it was a pleasure having you with us. Thank you
Thank you.
very much, and thanks, audience, and thank you
Yes.
for your wonderful questions and encouragement to the
Thanks.
Thank
speakers.
you, sir.
All
Thank
Take
right.
you very
care.
much.
Bye.
Thank you.
Bye.
Bye.